Hello, I'm Ron Waksman with Mike Jeff. We are at the ACC 2014. Welcome, Mike.
Thank you, Ron.
And we're going to talk Simplicity 3. The results were released officially in the New England, in the meeting. What do you take on the outcome? I mean, is that something that you expected, unexpected?
Well, when we all heard in January that Medtronic was taking a look because it didn't meet its primary endpoint, I think many of us guessed as to why. Well, now we see why. Beautifully run trial. Who would have imagined a control arm of patients who you could not control the blood pressure on 5 medications that now in a randomized trial has an almost 12 millimeter reduction in blood pressure? It's unbelievable. So the control arm did spectacularly well. I think the other question, Ron, and I'd ask you this, is how reproducible was the device? So you have to use that turning it every quadrant, right, to burn the artery. How often was that actually done in all the patients in which renal denervation was done? How experienced were the clinicians? I mean, you think about 535 patients.
111 operators.
Exactly.
I heard this, but I would say that when we did the study, we had a monitor and an engineer in the room,
Yep.
and they meticulously make sure that
Yep.
we have the impedance and we do all the ablation points.
Yep.
And if the ablation was not complete, we had to do another ablation. So I would say that I don't think it's the operators to be blamed. However, I did hear actually from Maury Esler that in his lab, when he looked on animals, at the best case scenario, he can ablate only 40% of the renal nerves. So and it's ranged from 0 to 40%. So if you don't ablate enough, why would you expect to see a robust effect?
So that's a huge issue, Ron, in that we have no way to measure whether the device actually did what it said it was going to do, right? We don't have a way to know.
If you're done or not done.
Exactly. And so how much do you have to ablate, and how do you know how much you ablated? We don't know. The other thing I think we learned from this is that patient selection is going to be critical. The more sympathetically driven the disorder is, the more likely something like this is going to work, right? So younger patient populations.
So how do you know who is like a higher sympathetic, oversympathetic
So
individual?
just by playing what we know in the literature, right? Younger people with hypertension tend to be more autonomically driven. Non-white populations tend to be more autonomically driven. Obviously other disorders like heart failure, more autonomically driven. I think those are going to be things we're going to have to think about in the future.
Yeah. So with respect to the technologies, there are a lot of technologies there. And it looks like that all of them reported the same amount on their feasibility phase 1 study. And you've done many of the ultrasound evaluation of the kidneys, and you've seen relatively safety report. That's what they report. But what do you take on the efficacy? It makes sense that all of those patients, they all were on 5 medications, but all of them, regardless to the technology, balloon-based, RF-based, liquid-based, they're all going to be showing the same efficacy?
It is striking how similar the feasibility data has come from a whole multitude of efficacy types.
Across geographies, across everybody.
I do think, however, that the randomization to a control arm changes the level, and that's what this study showed, right? It showed the control arm performs better in a clinical trial. The sham issue is a tough one, quite honestly. As a doctor who refers patients to people like you, knowing that my patient might actually get an arterial puncture and no treatment is an ethical question for me. That would really have to be somebody who I was convinced I could not control their blood pressure on whatever I could do. But I think you're right. It's very interesting that the feasibility data has been very consistent across technologies. I think this has to really make people think about it.
A few months earlier, there was the results of the CORAL trial, and you were involved a lot in renal artery stenosis and stenting and ballooning and all of the above. So is there any similarities and dissimilarities between these two trials that we can learn from?
So I caution people not to draw similar conclusions from CORAL and from this. So let's just remember that what CORAL did, in my estimation, was it confirmed the ACC/AHA PAD guidelines, which say you should offer optimal medical therapy for your patients with renal artery disease and hypertension, and only if you can't control them should you consider a renal artery stent. I think that's what CORAL showed. And that's what you've done in your career, and that's
Correct.
what I do in my career.
That's what we're doing on a daily basis.
Exactly. So I don't think CORAL means that renal artery stenting is over at all. Different patient population in Simplicity HTN3.
What's the next step the companies should do now? I mean, if you would have to advise them, obviously they're not going to repeat exactly the same trial because it's going to show the same results. So what should they do? I mean,
So, you know, there was an interesting table in the supplement, the New England Journal from Simplicity HTN3 that looked at the percentage, not the actual number, but the percentage of patients who had a greater than 5 millimeter and a greater than 10 millimeter reduction in systolic and diastolic blood pressure at 6 months. And it turns out that comparing the treatment arm to the sham arm, the group with the treatment arm was statistically better in 5 and 10 millimeter reductions in systolic and diastolic blood pressure. So maybe it's a negotiation with the agency about a different primary efficacy endpoint. Maybe it's not an absolute reduction, but maybe it's a percentage of patients who meet a goal as opposed to an absolute reduction. That could be one thing. I don't think the sham is going to be able to be negotiated away.
No,
I think the FDA is convinced that that's got to be a part of this. And then, of course, the other thing I would say is that when you actually measure the blood pressure to enroll somebody in the trial, I would be much more rigorous than what was done in HTN3. HTN3, as you know, you brought somebody in the office, you did 3 measurements. If it was above it, you're in.
And 3 weeks on the, or 2 weeks on the medication.
2 weeks on the medication. In this case, I would actually measure them in 2 different office visits separated apart from each other and make sure that they're in some range of each other. And of course, a company might say, well, that's going to make it harder to enroll. It's another step. But the truth is, what do you want? Do you want a fast enrolling trial that doesn't show your endpoint? Right? I don't think so.
Or the ambulatory. I think the ambulatory is probably more reflecting an office visit.
So the challenge with ambulatory blood pressure, as you saw in HTN3, is how much lower the blood pressures were on ambulatory blood pressure. Right? Exactly.
Yeah. Good. So you think it's going to continue, right? I mean, people are not going to stop here.
Look, if you take patients who are on 5 drugs, whose blood pressure can't be controlled, and you can lower their blood pressure by 14 millimeters of mercury, you're doing something. We just have to pick the right patients, include them correctly, and then make sure that we try and figure out a marker that we actually did what we tried to do with the catheter.
Yeah, I would submit to you that if this was done on the real true hypertensive patients, probably they didn't have such a larger sample size, and they could have been replicated what was shown in Simplicity 2. But I think the diffuseness of the definition here probably hurt a lot the trial.
Maybe so.
Thank you so much.
Thanks, Ron.